Hey everyone, Ryan here. I decided to do the video for CPAP application within my service. Just so you know, I didn't, not just picking a super quick, easy video, I did go down the rabbit hole and have a good long read this week about CPAP and the use within cardiogenic acute pulmonary edema. I'm going to go over the references, so please feel free to have a pause and have a look at where I got my references, and feel free to email me or ask me further about them. But I'll just hover over them quickly so you can have a look. So Tintinelli's through the acute heart failure section there. So physiology, alveolar tension, that's a very good thorough understanding about the lungs itself and the alveoli. So lung sound, specifically looking through auscultations, why we hear what we hear. So this article here had a good look in regards to patients who receive CPAP with cardiogenic pulmonary edema and the positive results that came from it. And this is another good one arguing the same. So yes, did go down the rabbit hole, and you're coming with me. So CPAP, the shortened version of it, due to the cardiac failure, left ventricular failure, it results in an increased hydrostatic pressure within our pulmonary vessels. This causes the fluid to leak out within our alveoli. With the extra fluid within our alveoli, this causes an increase of our surface tension within our alveoli, with the surfactant's role being to decrease it. It's unable to keep up. What happens here is that means that the alveoli collapse when we exhale. So when we auscultate a patient in APO, we hear a popping sound upon inhalation. So the role of CPAP is positive pressure ventilation. So this causes the alveoli to be splint open with the constant positive pressure. So very super quick overview of CPAP and its role. I went down the rabbit hole and you're there with me now. So I've got my phone set up. Hopefully you're going to be able to see what I'm doing nice and easily. I'll do my best to try and keep in screen with it. So what I've got written up, so this is our CPAP through the positive pressure airway, constant positive airway pressure via the FlowSafe 2 device. So we are utilizing our clinical work instruction here. You can see it there, so Ambulance Victoria, that is what we need to follow to utilize it safely. I've got up on the top right what that reference is. I've got the packaging, comes in a nice little neat plastic package, and there's only 2 items within it. Comes with our mask and the head attachment attached. And we've also got the oxygen tubing and the connector to the mask. So our indicated use, patients presenting with cardiogenic pulmonary edema that is deemed severe, and what our bosses deem severe is full field crackles heard on auscultation, or patients with the shortness of breath and crackles that are unresponsive to nitrates. Contraindications to use: patients who have altered level of consciousness, so GCS score less than 13, patients with facial trauma, patients with suspected pneumothorax, patients who are active vomiting for understandable reasons, patients with life-threatening arrhythmias, so patients who have APO but it's a reversible cause, particularly things like your VTs, SVTs. We're not to utilise the CPAP, we are to fix that problem first. Patients require airway management. What that means, if you're considering the use of OPAs, NPAs, LMAs, endotracheal tubes, you're not to be utilising the CPAP mask. Patients that are hypoventilating, so patients who already have low rest rate, they're probably already going to have a decreased GCS score, but our hyperventilating patient, we are not to utilise the CPAP. I've made a note over the side here, so hypertension is a precaution only with positive pressure ventilation. I'm sure you're all aware of it now, but positive pressure ventilation, it can cause that decrease in venous return, so adding that extra CPAP involvement would knock off their venous return as well, causing a crook patient. So I've got Manny here. I'm just going to quickly show you how we use it and how we are to apply it. So important things to note is that obviously this is going to be intimidating for the patient, so lots of reassurance required. You're to turn it on and plug it in. So oxygen tubing goes into the regulator. They recommend to set it up approximately 8 litres per minute to begin with, get some air flowing through it and get the patient accustomed to it, so having it as close to their face as they can stand. And then you are to be applying it to the face and putting the headrest over the top, making sure that the top of it, the bridge, goes over the nose and goes all the way around the mouth. This goes all the way over the head. We have 2 little forehead blocks at the top. I'm not sure you can see it very clearly, but there are 2 white blocks here. So we make sure that this is attached to the forehead or pressing against the forehead. And then we have 2 blue clips that we click into the side. And the rest of it now is adjusting to make sure it's nice and firm. We're not seeing any air leakages. So we have Velcros and that around the side up the top, making sure that it's applied properly to the top of the forehead, as well on the side to make sure they're not getting air leakage around the bottom. It's at this point that we start looking at adjusting the amount of air and the oxygen that's coming through it. The goal is to aim for 10 centimetres of water, which a good estimate is approximately 12 litres per minute of oxygen flowing through it. And this should be everything you need to do. There are lots of things that need to be looked at and constant monitoring of the patient afterwards. There are indications for removal, particularly if the patient's GCS score drops, patient becomes agitated, non-compliant. A lot of it comes down to paramedic discretion. Please feel free, ask any questions you want. I will do my best to answer, and if you guys need an updated video, I will more than happily provide.